Good evening, everyone. Tonight we have Dr. David Smith with us. He is an MIT trained engineer who did his medical training at the University of Chicago. He has been a practicing physician for over 30 years. Dr. Smith is an orthopedic surgeon with Bone and Joint Physicians. They have multiple locations with offices in Oak Lawn, Orland Park, Flossmoor, and Calumet City. As we go through the presentation, if you think of any questions you'd like to ask, please type them into the webinar panel and we'll go through them one at a time once the presentation is complete.
Hi everyone, my name is David Smith, and thanks. I see some familiar names out there. Ken, welcome. We'll try and answer there's some folks have submitted questions, and we're going to get to those at the end. So if you can endure with me here, I'm going to run through some general things about knee problems, and hopefully we'll hit some of the questions you might have, and then we'll go back and answer the specific ones. I'm going to move kind of fast because it allows you to kind of get through this basic framework and then leave plenty of time for questions if you want to type some in. So let's see here. So we talk about knee problems. Basically, when I think about when patients come in, what do they complain about? It's either pain or the knee's unstable. In other words, it feels too loose or it feels too stiff. So those are common complaints. This is something I use in all my talks, and I've kind of kept it in mind through all the years I've been in practice. And that's when I see a patient, there's several questions I feel that I need to answer. First is, what's wrong? In other words, what's the diagnosis? Next question is, well, what can you do about it? And usually there's more than one thing. So I think that framework is what we want to provide to you, for whether you're seeing an orthopedic surgeon or a cardiologist or a dentist. It's, what's the diagnosis, what's the problem, and what are my choices? And then the last question is, how can it turn out? And we know there's no absolutes in life, but in general, you can ask someone's their experience. In other words, when you do this, are 80% of the people happy, or 20%, or what's the downside risk? I often use the example of Sherlock Holmes in answering that first question, what's wrong? Actually, Conan Doyle, who wrote the fictional character Sherlock Holmes, modeled him after a physician in Scotland who was a brilliant diagnostician. He could look at people's hands and various physical things about them and know what kind of work they did. So we're going to try and mimic the detective. And what does a detective do to get answers? He gathers information. And for a doctor, it's the history, really important, physical exam, x-rays, ultrasound, and MRI. Let's talk about each just a little bit. Patient history. I know everyone gets online, just like we're doing tonight, and Googles everything. I know I do that, whether it's my car or something around the house, and you get a lot of answers, and that's great. But I like it when you come and talk to me. It's like you're talking to your neighbor or a friend. I like to just explain it to me, what part of the body hurts, what makes it worse, what makes it better, instead of getting, occasionally I'll be talking to a patient, I just want to hear what's going on, and they'll go, well, I know it's not my meniscus, or I know it's my meniscus, and that kind of clouds the thing. I just want to know what your symptoms are. So it's really important, though. Physical exam, despite all the fancy tests that we do nowadays, there's really nothing like laying hands on and examining the body, because often we have advanced tests like MRIs that show us some abnormalities that really aren't the cause of the problem. And I think you need to keep that in mind. If you get an MRI of the knee of someone who's 65 or someone who's 25, what might be considered a pathologic disease process in someone 25 would not be in somebody 65. Some are just age-related changes. X-rays. Oftentimes I get questions, the patients say, well, I went to the doctor, got an x-ray, and he said everything was fine. Well, everything was fine with the x-ray, meaning, there was no fracture, there wasn't a bone-on-bone contact, you didn't have large bone spurs. But there's a lot, that only shows one part of the knee structure, and you need more advanced tests. What are we looking at basically is the space between the bones. And when it gets really narrow and gets to bone-on-bone, that certainly is an advanced stage. But even narrowing is suggestive of the arthritic process. And often patients come in, they'll bring their x-rays, but they're not weight-bearing. Really important for us in orthopedics to get x-rays of you standing. Ultrasound. Some of our patients can't have MRIs. They've had stimulators of some type in their body, some type of metal that doesn't allow them to have an MRI. And this shows an ultrasound. Basically, it's a sound wave. We bounce off body parts, and here's one of the knee that I've done, and it shows this white line here is the border of the bone. So when it hits something really hard like bone, the sound waves reflect. And this little triangular thing here is actually the meniscus, and the dark area here is a cyst. So that's one more test we can do, fairly easy. And here's the, I don't know if you call it the granddaddy, but the ultimate test thus far that we use a lot of, and that's MRIs. On the MRI, we can see the bone. We can actually see inside the structure of the bone and look for abnormalities there, showing color differences. It's on a gray scale like the old-fashioned black and white TV sets that my generation grew up watching. And we know certain structures should be black and certain structures should be more white. And so changes in shape and color tell us a lot. And we'll be talking about the anatomy. This is looking at a human knee from the side. Here's the patella or kneecap in the front. This is the thigh bone or femur, sort of shaped like a wheel. This little gray, looks like icing on the cake, is really cartilage. The fundamental thing that is destroyed in arthritis and needs to be preserved for healthy function. Here's cartilage on the other side. And here's a special type of cartilage called the meniscus. We'll be talking about that. Here's an interesting book. I read this some years ago about a man named John Hunter, lived in the 1700s in England, and he taught anatomy and became a great physician or surgeon by his study of anatomy. He learned a lot about disease processes at a time in the 1700s where there wasn't a whole lot going on other than the study of cadavers. And we're going to follow some of his example and look at anatomy. Here we're looking at a picture of the knee, sort of simplified. Really what goes on in the knee, there's four bones. Your femur or thigh bone meets the tibia. That's the main transfer of body weight as you walk. What makes it possible for those bones to make contact and not have pain when you bear weight is this white material, cartilage. These pads, the meniscus, provide additional cushion to help preserve that cartilage. It gives a little stability to the knee so it doesn't slip out of place. And then there's these four major ligaments that give stability. And we'll be talking about each of these things, but these are called collateral ligaments on the side. There's one on the big toe side of the knee we call medial. The outside, the little toe side, we call lateral. So little toe starts with L, and so does lateral. So lateral is the little toe side. And then inside are two cross ligaments, the cruciates. You hear about the ACL and the PCL. And then above are the muscles that control the knee, really important, the quadriceps. It's a very powerful muscle that helps straighten the leg and really gives you support when you walk. So just like a detective or you're watching a mystery show, after a while you start thinking, well, maybe that guy did it or this guy did it. And you have your list of suspects. Remember the old game Clue? You're trying to figure out that board game where we'd play when we were kids. So what are the suspects in the knee? When I see a patient come to the office, have knee problems, I'm thinking, well, did they tear their meniscus, that pad? Have they had a ligament tear recently or an old tear that's caused too much looseness in the knee and it's resulted in arthritis, loss of cartilage, and secondary inflammation? Or do they have loose bodies? Part of the arthritic process, and sometimes just injury, people will break off little portions of the knee, either cartilage or bone, and it'll roll around in the joint and get caught occasionally and cause severe pain. So that's loose bodies. And synovitis, what is that? Well, in medicine, when you see this itis on the end of a word, it refers to some type of inflammation. And the synovium is the lining of the joint. If we went inside, I know at the Museum of Science and Industry they used to have the heart you could go inside of. I don't know if they have a knee, but if you went inside a giant knee and felt the walls of the knee, you would feel this slippery material, almost like cellophane with vegetable oil on it, and that's called synovium. And when your knee gets irritated, the synovium gets reddened and starts to overproduce fluid. So these are common things I'm thinking about when someone comes to me and says their knee is bothering them. What if the diagnosis is arthritis? This is a common one. I see a lot of people with arthritis. I do a lot of joint replacements and arthroscopy, and this is one of the more common diagnoses. What is arthritis? Well, if you went to the library and asked for all the books on arthritis, you better bring a big truck with you to pick them all up. So it's fairly complicated, but in some ways it's not. It basically is a process that results in the loss of that tread or cartilage off the end of the bones. The most common type we're all exposed to as we age is called osteoarthritis or degenerative arthritis or wear and tear arthritis. And they're elements of mechanical problems, cartilage loss, bone spurs, hardening of the bone called sclerosis, cyst formation. Those are the mechanical problems. And then there's inflammation. That's that redness that occurs in the synovium. And I think it's important to keep these in mind. And the reason I like to do that is because when you have pain, if you think, well, what causes the pain? Well, one thing could be inflammation. The other could be a mechanical problem. So if you go to the doctor and you get a treatment and you go, this is to help, let's say cortisone shots or anti-inflammatory pills. If 80% of your pain is coming from inflammation, then you might hope that 80% of the problem will go away if you get rid of the inflammation. However, if 80% of the problem is mechanical, in other words, you have a loose body, a torn meniscus that's catching and irritating the joint, it's almost like having a nail in your shoe. You can take all the pills and shots you want, but until you get that nail out of your shoe, it's going to keep hurting. So it's good to make a distinction because early on, a lot of people, their arthritis is primarily inflammatory. They do well. They come in. I've had patients come in for years, occasional cortisone shots, and then finally they start not working. And the patient will say, are you sure you're using the same stuff or you got it in the right place? And the reason is often is that joint is breaking down and the mechanical aspects are becoming more significant. Just so you can get kind of oriented, this is a human knee from a cadaver. We see the kneecap here in the front. This is the capsule, and it's hard to show this on any anatomy animations, but it's a light, pliable, it's almost like a t-shirt. You know, if you're going to play basketball with someone and you put on a t-shirt, it's something that you can easily move, but when it gets thickened, you lose that flexibility. So let's look at this little schematic here. On the left side of the screen, as you look at the screen, it's normal. On the right side, osteoarthritis. This yellow thing is meant to represent the femur. The white is the cartilage. So if we look in here, this green is the capsule, what we just showed you on that human anatomy picture. It's kind of thin, flexible. It's more the t-shirt. There's the synovium, that tissue I talked about that produces fluid. It produces just enough fluid to lubricate the joint. Let's look at an arthritis side of the knee. We see thickening of the capsule, and that causes stiffness, causes pain when you need so much mobility to get through life's getting in and out of cars, up and down stairs, walking. When that capsule gets too tight, you can't use that joint normally. Freezes up the hinge. There's changes that occur in the cartilage. These fragments come loose. They become embedded in the synovium. They cause it to overproduce fluid. People come in, they have tightness in the knee. It's swollen, the old expression, water on the knee. And as the cartilage loss continues, you get these changes in the bone where it actually becomes harder. So there's less cushion, and that just accelerates the whole arthritic process. So you can sort of see it's a domino effect, and these changes that occur have consequences later on. So we said we wanted to answer the first question, what's wrong? So we talked about some of the things that could be wrong in the knee. What if the answer is arthritis? What are the options in that? And I use this thing, I call it the 5 fingers, just kind of a little reminder for myself. What do I do day in and day out is I either send people to physical therapy, recommend medications, pills, give them injections, recommend a brace, or recommend surgery. Let's talk about each briefly. Physical therapy. I think anyone who has sufficient arthritis to see a doctor probably is going to benefit from therapy because those things we were showing you on this schematic, that tightening of that capsule is so critical to not let that get overly tight that I think a session or two with a therapist is really worth it. The other thing is the muscles around the joint get weak. And sometimes even people say, oh, I just keep getting on the treadmill and walking. There's a thing called reflex inhibition that occurs with arthritis. And you have to go a little above and beyond to keep those muscles strong. And study after study has shown that if you can strengthen those muscles, you can diminish some of the pain. You're not going to cure it all, but you can certainly help. Here's a rule we tend to follow. A stiff knee is a painful knee. So we have this thing called knee arthritis school. We kind of model it after a guy named Shelbourne, who's a well-known knee surgeon. He started out this process of improving the knee through first working on extension, getting it so you can get your knee straight. A lot of people I see, when they come in and I examine their knees, they can't straighten it out. It's subtle. It could be 2 degrees, 3 degrees, 5 degrees. Probably wouldn't notice it if you saw them walking around in shorts at the grocery store. You wouldn't think they had a flexion contraction, but they do. And that little bit of flexion really increases the stress across that joint. It tires the muscle and causes pain. So first thing we do with the therapist is get that leg straight. Flexion, really important to get through everyday life. You need 115 degrees of bending to get up and down stairs comfortably. You need a little beyond 90 degrees to get in and out of a chair, probably 110 degrees. And then the final thing we work on is strength. So those are the things that therapists do, and it really helps a lot of people. They also look at what we call gait, which is how you walk. I just saw a lady today that had a knee done by someone else some years ago, and it was starting to bother her. So I sent her to therapy because she's got some problems with the knee mechanically, but what we want to do is get the therapist to show her how to manage that problem through exercise and making accommodations in how she straightens the leg out when she walks. They also can help us. A lot of times therapists will come over to me and they'll suggest an orthotic or a brace, and they look at the entire joint, not just the knee, but also the hip above and the foot and ankle below. And you can see why changes in how the foot and ankle meet the ground. Here's it straight and here's it out to the side. It has an effect on the knee, and it can be helped with something as simple as a Dr. Scholl's foot pad. Medications. There's lots and lots of pills, hundreds of anti-inflammatories. Most of them are prescription items. Most of them are expensive unless there's a generic form. So we won't go over all of them, but they're called NSAIDs, non-steroidal anti-inflammatory drugs. Basically Motrin, Advil, Aleve, aspirin, Indocin, on and on. There's a few other things now. There's some gels that you can rub on that actually work these anti-inflammatories in without taking a pill. I think it has some advantages. Expensive. These pharmacies really hit us on this stuff, and I'm not sure exactly why. I had a lady from Poland the other day, and she can get it over there very inexpensively, so makes you wonder. But it does work for some people very well. Cosamine DS. This is a non-prescription item. It's not a non-steroidal anti-inflammatory. It's what's chondroitin sulfate glucosamine. Kind of a mouthful. You might see it more in a health food store. It doesn't regrow cartilage. It doesn't heal the cartilage, but it does have a mild anti-inflammatory effect, and I certainly don't discourage the use of it, and I think it's worth a try, as I don't see much risk with it. With NSAIDs, the Motrin, Advil, Aleve type products, you got to watch your stomach. It can cause fluid retention, increase your blood pressure. It can cause ulcers. So there are significant risks with those medications. That's why I often think that the injections are a good substitute. If you can manage an arthritic knee with occasional cortisone shots, I think that can be very effective. There are 3 types of injections we give, and nowadays I think through using a variety of different approaches to the knee, we can give these injections with minimal discomfort, sort of put it in the range of a pinch. I'm sure I might have a few of my patients I've injected might disagree with me, but I think most times we can do it, and most times after we give the injections, people will say, oh, you're finished, that's it. You know, they're expecting a lot worse. So cortisone, strong anti-inflammatory. Viscosupplementation. This is something started probably 15 years ago. I've been giving these for about 15 years. You'll hear the name Supart, Synvisc. It's a chemical called hyaluronate that was found to be low in people with arthritis, in their knee fluid, in the lubrication of the synovial fluid. They found ways initially from getting it from chickens, and then there's some chemical ways. They do it, cellular techniques. But again, I have lots of patients that get these, and they'll come back year after year and get them repeated. You can't give it any more than every 6 months. Most people, it's once a year. And it's not something you become dependent on. Patients often ask me if they started, or am I going to be dependent on it? That's not true. It's the only way they become dependent is if it works for them and they think it was worth repeating. Platelet-rich plasma is in your blood, or well, let me just kind of go through this. Cortisone injections, I think people overly concerned, they hear about these athletes got their knees injected all the times and, quote, their cartilage disappeared. I think they forget that a lot of their ligaments were damaged. They had high impacts to the joints. They developed arthritis because they played a violent sport. And like anything, it can be overdone, but cortisone is a good means for those of us in our 60s, 70s who want some treatment for the pain. These are the gel injections. PRP, platelet-rich plasma. In your blood are red blood cells carry oxygen, white blood cells that fight infection, and platelets that are involved in wound healing. And they help form a clot when you cut yourself. And they also release these little packages of chemicals that coordinate other cells coming in and repairing the injured area. So there's some hope that by doing this, it would help cartilage. It's not approved by any insurance company that I'm aware of. It's not paid for by Medicare. I think it's considered experimental, and I wouldn't disagree with that. It's expensive to get. We do it for patients who want to give it a try. They hear about these athletes, and I do think it works for some people, but it's not magic. You don't want to overstate it. Bracing, really an important option. I often recommend when you're at the grocery store, look at some of those elastic sports. You can't turn on TV without seeing Brett Favre advertising something. They've got these copper bracelets. And I don't know if the copper does anything, but they're simple elastic braces, and they do help some people. We go all the way to the custom-made expensive braces. That's an option, and certainly if people have questions, we can talk more about that. Surgery. Two major categories: arthroscopy, where we go in there and clean out the joint. I've had lots of patients that I've managed for many years. As they and I grew old together, basically they would be men, and a lot of times men, sometimes women in the trades who had knee problems and really needed to keep working to take care of their family. And we'd try injections and medications and braces, and some of them kept on having problems, and it was limiting their ability to work. And we would scope the knee, clean it out, and for 2, 3, 4 years in some cases, they would do better, respond better to treatment. So it's something to think about and discuss with your doctor. How to do a knee replacement. This is a big decision for people to make, and I start out with this thing: why planes don't flap their wings. I mean, I don't know if many of us think about this, but when you try and mimic what nature does, you got to use different materials. And so I think it's important to understand a total knee is not the same thing that nature or God gave you. It's a substitute. It's artificial. You have to understand its limitations and who are good candidates for it and who are not. So we'll stop flapping our wings and just start talking about what's involved in doing a knee replacement. It's an attempt to reproduce the function of a natural structure with an artificial device. I think that's important to keep in mind. You look at normal human cartilage. When it gets to this stage, there's no known way. I often get asked about cartilage transplants. I went to Sweden about 15, 20 years ago to learn how to do that. We can only patch small areas. You can't realign this. You hear things about stem cells. There's a lot of, America's a wonderful country and people love to advertise, but basically for someone who spent his life doing this, I can tell you practically that when you get severe arthritis, the only thing at a certain stage that's going to reestablish some balance to that joint is a joint replacement. Stem cells, cartilage transplants are really intended for small areas in younger patients who've had some trauma. So what's our goal when we do a total? Well, it's painless function, and both are important. So what are the 4 P's? Patient, procedure, prosthesis, physical therapy. Those are factors I think need to be considered when you're having a knee replacement. The first is yourself, the patient. As we walk down the street and we look at each other, we all look a little different. Some of us are slimmer and some of us are a little heavier than we should be, and that can have a role in terms of how much benefit you get out of a knee replacement, how safe it is, a higher risk of infection if you're carrying more weight. But for a lot of people, they've got themselves painted into a corner. So we all struggle. A lot of us struggle with our weight. and you want to do the best you can, but sometimes once you get arthritis, you can't exercise. It does get harder and harder, but you need to recognize that does add a little bit to the risk. The other is leg alignment. The normal knee alignment should fall right underneath the hip and go right into the ankle. Some people are a little bow legged, some are a little knock-kneed. If you let that get too far out of whack, that capsule gets stretched out, it gets too tight on one side, too loose on another side. And we don't have another capsule to put around that total knee. We have to use the equipment you come with. So body size, body shape, also other diseases that you have. We know, unfortunately, a lot of us, as we've gotten older, have gotten more type 2 diabetes. It does increase the risk of developing an infection if you don't have good control of your blood sugars. Hemoglobin A1C and your fasting blood sugar, you really need to get that under good control. Lymphedema. Some of us have venous insufficiency. Some of us get swelling in the legs, and again, that's a complicating factor, can affect the wound and the healing. Smoking. There's many, many reasons we all know not to smoke. Unfortunately, some of us have went down that road, and it's a hard road to come back from. But it does, again, increase the risk of infection, complications, wound breakdown. Neurologic problems. I see folks that have had, I guess what you'd call a small stroke, or it left them with some impairment neurologically, some weakness of the muscles, imbalances. I see diabetics who have a thing called Charcot joints, where they don't have good feedback sensation. I see folks that have had Parkinson's disease. So again, another factor. So that's just to emphasize that one point. You know, some folks come in and they'll say, well, my neighbor had it done, he did great, or my neighbor had it done and he did terrible. Well, you have to look at the differences in you and your neighbor, and also the fact that you have to look over a wider spectrum of people than just one case. So your pre-op health, very important. The procedure itself, this is the surgeon's work, and certainly we need to do everything we can to put it in give a person a chance of a good outcome. Pre-op planning is so important. We spend a lot of time. Got a total knees I'm doing tomorrow, and this afternoon I went through the x-rays and looked at them and the sizing and making a lot of decisions about the implants and little subtleties of how I'll anticipate, because the more I anticipate and the more I plan, the smoother things go during surgery. Surgical technique is really important. I don't use a tourniquet. I use a computer-assisted navigation. I think these are really important. I do the entire operation skin to skin. You might say, well, doesn't everybody? Well, one thing I've seen develop over my career is some of the universities and some very good surgeons and very busy surgeons will assign different parts of the operation to their assistants, sometimes residents, sometimes fellows, and that's not saying that's bad, it's just something you need to be aware of. It's who does the work. So here's some of the planning, some of the x-rays we do, and there's a lot of factors we have to go over. I won't necessarily bore you with all those, but you can see there's a lot of things to consider beforehand. We also want to look at the alignment of the leg, because that's one of the first things we have to do when we're going to make these cuts in the bone to reestablish that joint. But it's no longer a normal, well-aligned knee. That's why you're having the surgery. So we have to sort of sort out what that knee looked like in healthier times. One thing I do is I call exam under anesthesia. Once the person's under anesthesia and I can comfortably move their leg, make one last exam of the leg, because the soft tissue capsule that sits around the knee, it's not just carpentry, it's not just cutting bone. It's interrelating those cuts to the soft tissue. And some of those capsules are never going to stretch out again, and we have to anticipate what limitations we need to accommodate for. So this is that exam under anesthesia. Person's asleep. We're examining the leg. I don't use this tourniquet. Now this thing shuts off the blood supply to your leg for an hour or more, and I think that does result in more pain. It can result in some weakness, damage to nerves. So probably 90% of surgeons do use tourniquets still, but you're seeing a trend now toward not using them for this. So also every little detail makes a difference. I use a thing called an insole, a capsular cut. It's a straight cut, and I think when we close the joint up, I think that allows us to balance the ligaments out better. Computer-assisted surgery, to me, is the gold standard, but a lot of surgeons don't like to use them. They think it slows things down and it's expensive, but I think it's cost-effective in the sense that if you can have one operation, get a good result, it's sure a lot cheaper than doing it again, one patient at a time. So one surgeon concentrating on one patient and going on to the next one, I think is the way things should be done. So this just shows the straight cut, the curved linear cut. What are we trying to do? If you were building a house and when you were finished it was leaning like this, it wouldn't be what you want. You want a house that's sitting straight. It balances things out. And this shows a plumb bob, just dropping it down from the center of my hip to the center of my knee. That's what we're looking for. Now, you're on an operating table. How do we get that straightened out? How do we get that geometry? Well, there's three ways to do it. For many, many years was using these rods. We drill a hole in the end of the bone, put this rod up the femur. It did cause some problems. You were pushing marrow and fatty tissue into the blood supply there, and it did cause some health issues for people. Occasionally, a thing called fat emboli occurred. Not that frequently, but it could occur. Nowadays, there are some attempts using various systems, taking measurements from an MRI or a CT scan and make a mold that will be put on the knee at the time of surgery to make the appropriate cuts. What I don't like about that is you're doing all your sizing beforehand, and I think you need the flexibility of what I consider the gold standard, computer-assisted navigation. There's the rod, and I think most of us can see why we might want to avoid that if we could. Here's the custom cutting blocks. Nice, simple. Some surgeons like it because it's fast, but to me, it reminds me a little bit when I was a kid. They put this thing on your foot and measure the width and all that, and then they bring out a pair of shoes that supposedly were right for you because this thing said it was. You tried them on and you weren't comfortable. So that's why I try and make all those adjustments right up to the last minute before surgery where we're looking at the flexibility. And this computer, this is the output we get on the computer. Really helpful. What I'm doing tomorrow, I'm going to make a little millimeter shift. I'm going to make a slight adjustment. You can't do that with the other system. So this is what it looks like. Ingalls has this system. They bought it from me some years ago, and we've used it for many years. And it's a diode thing we put on the little cutting guides and allows us to establish a coordinate system. What else do I do to get that balance right? Measured resection is one technique people use. That's sort of saying, well, I'm going to put in 8 millimeters of metal at that end of the knee, and so I'm going to cut off 8 millimeters. I use a technique called gap balancing where we look at the soft tissue, how springy it is, how tight it is, and that allows us to adjust the cuts to the soft tissue. So our third finger is the prosthesis, the implant. And I think everything makes a difference. You can have a partial called a uni. You can have a CR knee. You can have a posterior stable. What's the difference in general? The fact is, a uni you preserve, there's 4 ligaments in the knee we were talking about. This preserves all 4. A good uni will always be a good total knee. And you have to select the right patient for it. Lady I saw today was having a problem, had a PS knee, and some of the problems she had, I think, is a little bit unique to that. Now, there's nothing wrong with PS knees. A lot of doctors do them, but if I can, I want to use that CR knee and preserve 3 ligaments instead of just the 2. I think it gives you more feedback to your brain about where your knee is at the time you're walking. I think that has advantages. So when we're looking at making these cuts in the bone to reshape it, these ligaments that was shown in this little plastic model are really key. So what's a partial knee replacement? Well, that's, you got one bad tire, so you just replace that tire. And this, the most commonly, is on the big toe side we call medial. These are excellent. I love doing them. But for some folks, it's not the right thing because they've worn down the other parts of their knee. So the human knee, we talked about 3 compartments: medial, lateral, patellofemoral. And you can kind of see the progression. This is the all-back system, and for a person with a grade 2 or 3 all-back would be candidates for a partial. When you get to this point, it's too late. There's really nothing you can do other than a total. So that's what the uni looks like. We're only replacing the worn portion. It reestablishes the gap balance. A very good system, again, if you're a candidate. So sometimes it's because people waited too late. In other words, they initially had only one compartment involved, and if they could have balanced that leg out, it might have kept them from going to the point where you needed either a CR or a PS or even what we call a constrained knee system, where you've lost more ligament stability. So those are the basic categories we look at. If you have questions, we'll go over that. This shows a total knee compared to a uni. As you can see, it's more surgery, bigger implant. But if it's not going to help you to do the small one if this is what you need, even though this is easier on the patient. If this is what your category you're in, you need to accept that. So here's a CR knee, here's a PS knee. The difference is this peg that sits up there with plastic. And when I don't like them, I've used them when we have to, when the posterior cruciate ligament is gone. But I think there's more plastic wear from that. I think it's more natural to leave your ligament. The other thing is the axis of rotation. And the system I use, called Stryker Triathlon, has a fixed radius of curvature. And I think it has some advantages. Again, I won't bore you with all the details. Others use what's called a J curve, and it's a sliding thing. And I think it's much better to get full straightening, full extension, full flexion, and stable in between by using this fixed radius system. Post-surgical physical therapy, really critical. A lot of my patients, I like them to go before therapy to kind of get started. If you got a flexion contracture, let's try and get rid of it. And then understand your exercises you need to do afterwards. But I think 50% of the success is due to what you and the physical therapist are going to do afterwards. Even long term, I occasionally see people, they're 2 and 3 years down the road, we're doing well with their knee, and they start to have some problems. It often reminds me when I was a kid, you want a dog or what kind of pet you want, and they always tell you, you got to take care of it. Well, probably we should do the same thing when we give people total joints. You need to take care of it. So when you're in physical therapy, you want to learn those exercises, and you want to keep doing them to some extent. I know you're not going to get up every morning and do jumping jacks and like you're in the military, but if you let those muscles atrophy, your total knee over time can get tight again, just like any knee. But a natural knee has a little more ability. It's more like that bird. It's a little more resilient and able to accommodate than that jet. When that jet has a problem, you need to get the mechanic to work on it, and you're going to be the mechanic. So physical therapy, doing your exercises, keeping it stretched out. So if you do get to the point, total knee, where to do it, who to do it. One thing that's consistently come across is you want to go someplace where they do a lot of them, both the hospital and the surgeon. Ingalls is such a place. For many years, we've been doing a lot of total joints, and I think they have an excellent team there. This is a team thing. It's not just one person. It's the nursing, it's the OR staff, it's the surgeon, it's you, the patient, but Ingalls has got a great team, and so just something to know. So hopefully that's been a quick flyover of knee problems. Maybe we answered some of your questions, maybe we confused you, but now's your chance. If you got some questions, let's hear them.
All right, so thank you very much for the questions that have been submitted so far. Let's see, first, my knee has been clicking and popping since the beginning of 2016. Currently, I use ice packs daily along with a knee brace. I have had 2 injections with no relief, also with an MRI that shows a tear, 0.4 centimeters in the meniscus, with some of the cartilage worn down. However, it is not completely bone on bone yet. Also with a bone spur on the right side. If I move ahead and have it scoped, what is the percentage that my knee will get better or worse by having this done?
Okay, well, good questions. Got a lot of things there. First is, when I talk to patients about treating a problem, you want to understand, as we talked before, about the pain generators. So we know a torn meniscus can be a pain generator. We know arthritis can be a pain generator. Now, if you were 20 years old and had that meniscal tear that you've described, and that was your only problem, I think there's a real good chance no one's ever going to guarantee results. There's a real good chance that you're going to have complete resolution of the problem. But if you've got arthritis, we don't have a cure for arthritis. We have treatments, and arthroscopy can help. Hopefully it could keep the tear from getting bigger. It could keep the tear from aggravating the arthritis. But as I told the patient, the first patient I saw this morning, similar situation, a lot of arthritis, torn meniscus. And I told him, I said, if I took an x-ray of your knee today and took an x-ray the day after I did the surgery, it'll look just like it does today. So what we're trying to do is work on the meniscal problem, try and clean up some of the wear particles inside the knee. It can be very helpful, but you need to go into it with realistic expectations. And let me just say this, talking to people, whether it's on the phone or on the computer, you need a doctor. You need someone that you have faith and confidence in, and someone who will explain things to you. And sometimes you just need time to think about things, and there's nothing wrong with researching it. But just because I say something here doesn't mean that applies directly to you. All I want to do is get you thinking about the various aspects of knee problems. So I really can't tell you if you had your knee scoped, even if I saw you, I can't tell you what percentage you would be. There's a chance you wouldn't be any better at all. There's a minimal chance you'd actually be worse. But I would say, just to give you some broad spectrum expectation, I'd say 2 out of 3 people in a situation like you described would probably benefit from an arthroscopy. If we describe benefit as saying you felt better for a period of several years after the surgery. That means a 1 out of 3 chance you'd go through it and still have clicking, popping, and the same problem you started with. That's just something you need to understand.
Okay, the next question is from a female age 62 who wants to know, does bone-on-bone diagnosis require a total knee replacement, or is there a minimally invasive procedure that can be done, such as cartilage regeneration or prosthetic spacer implant into the joint?
Okay, well, let me address that one. Bone-on-bone is a phrase, I think a lot of us doctors use it, and it's just to explain to the person that they have significant advanced arthritis. I have lots of patients who have, quote, bone-on-bone arthritis who have chosen not to have surgery and would appear been able to manage it successfully, not eliminate the problem, but to make life comfortable enough so they, at their point in life, say, hey, I can work around this with an occasional cortisone shot, taking some Motrin, wearing that brace you gave me, doing those therapy exercises you showed me, and that's their choice. Now, the only thing I will say is that if I kind of grouped people and had 50 people who had bone-on-bone arthritis and people who had arthritis but wasn't at that level, and we just followed those people along, my expectation would be that the people with the bone-on-bone arthritis, if I came back 5 years later, that a significant amount of those people would have joint replacement, more so than the milder affected group. So I hope that gives you some idea about it. But if you're really, I get a lot of patients who are just set against having surgery, and I understand that and respect that, and we work very hard to try and keep them comfortable, and that's a choice. And some of them it seems to work. So I wouldn't despair and give up all hope. It's worth trying some lesser approaches before you commit to knee replacement.
I've suffered with knee pain on and off since I distended my patella in high school. Since I've gotten older, I've noticed at times I get sharp pain in my knee where I have a limp for a while. I was told also all of the cartilage in my joint is depleted. Is there anything I can do?
Well, hopefully some of those questions were answered in our little talk here about the 5 fingers of treatment. That I mean the pills, the shots, the braces, the physical therapy, and the surgery, which includes arthroscopy, cleaning out the joint. Again, trying to really get a better understanding of exactly what's going on in your knee. Do you have primarily arthritis in the kneecap, patella? Do you have arthritis in other parts of the knee? Would the gel injections help you? Would a specific type of kneecap brace help you? So there are a lot of things that you can do. What I like to do is when I see a patient is, as we said, do the history, examine their knee, get some x-rays, consider an MRI, explain to the patient what you think the problems are and what you think the approaches are, and then work with them to find the thing that seems to be best for them. And sometimes you go down one path and you have to just back up and try a different one. Once you go down the surgery path, there's not much backing up. So, but I'm all for trying conservative things, but also there's a point at which you realize that it's just not going to work. But again, talk to your doctor, and again, hopefully by some of the things we talked about, you'll be able to direct your questions so he can inform you as to what he thinks.
Okay. After a fall, my knee was in pain. I had an x-ray and was told it was arthritis. I had a cortisone shot that did nothing. Still in pain. Can arthritis come out of nowhere? Never had a knee problem prior. I'm female, age 65, overweight, but work out 3 to 4 days a week.
Well, that story is very familiar to me. I see lots of patients. I'll get the x-rays, and I'll know those changes that have occurred on the x-ray have probably taken years to develop. And then I'll ask them, when did your knee first start to bother you? When did you first have a hint there was something wrong with your knee? And they'll go, 6 weeks ago, 3 weeks ago. So I think what you're saying is something that we see. Arthritis is a condition that degrades the mechanical integrity of the joint, causes wear. But like the old thing, the straw that broke the camel's back, a lot of times it's one simple thing. You slip going down the driveway to get the newspaper on some cold winter Chicago day, and your knee started to swell, and you thought it'd go away with Motrin, and you saw a doctor, you got a shot of cortisone. Sometimes when you light that fire, it just seems that one additional insult to the knee sets you down that road. So again, it's not surprising. It doesn't come out of nowhere. It probably has been coming on. It's just you've been fortunate and haven't had symptoms. But it gives me hope when I see someone that has arthritis, even bone on bone, and they've done well. Well, that says to me that they were doing okay with that mechanical setup, and then all of a sudden they had an insult to them, an injury. So it encourages me to try some of the non-surgical approaches, see if I can get them back to where they were before. Can't always do it, but it's a thought.
Okay, looks like it's our last question. 49-year-old male with pain in his left knee, got an x-ray, but nothing was found. Sharp pain on the right side of the kneecap when walking. When sitting, laying, or moving, it's mild pain. I wear a brace and take over-the-counter medication, but it wears off quickly. Also use pain rubs, but not getting any relief. Any suggestions?
Yes, certainly, and you listed your age as 49, and we see a lot of people, mid-40s, early 40s, and all into their 50s, with similar stories to yours. And I think it's really important when that pain persists and doesn't go away with simple things like maybe a single shot of cortisone or some medications. I think it's time to get an MRI. You could have a torn meniscus, and that might be able to help through arthroscopy and prevent some further damage down the road. So I'd encourage you to at least talk to your doctor and ask him if he thinks an MRI is appropriate. And once you get it and you get a diagnosis, then see if that correlates with what you've been experiencing. In other words, if you've been having pain that suggests possibly a meniscal tear and your doctor's examined your knee and goes, well, you could have one, and then you get an MRI that demonstrates it, then I think it's time to move from answering the question, what's wrong, to answering the question, what can you do about it? And at that point, arthroscopy is certainly on the table for discussion.
Well, thank you very much, everyone. I'd like to thank you for joining us, and if you Have any other questions, please visit us at boneandjointworld.com. You could submit them there. Also, we record most of these webinars. We do them about once a month, and the videos are posted on that website. Have a wonderful evening. Thank you again.